the way I interpret this topic, the future of JAK inhibition, could be looked at in twofold. One is with the approval and in some places pending approval of multiple JAK inhibitors, how does one decide in niches that each JAK inhibitor may capture? And then the second part of it would be a more forward-looking discussion about the future of JAK inhibition, perhaps as a backbone for combination strategies, either upfront or as a rescue for patients who are not having an initial response to monotherapy. So maybe we'll go with the first one. So if you have a patient, I'll take the same approach that Jean-Jacques did with the case. And so if you have a patient who has a platelet count of intermediate 2 risk myelofibrosis, symptomatic, has palpable splenomegaly with some early satiety, and has a platelet count of 75,000, I would call it gray zone of thrombocytopenia. In a world where perhaps there is 4 JAK inhibitors, ruxolitinib, fedratinib, pacritinib, and momelotinib, based on data at hand, how does one decide which is the ideal agent to start in a patient who has a modest thrombocytopenia?
Maybe I could start. I always love ruxolitinib, to be honest. And, we have learned to deal with it, and even with the dosing and thrombocytopenia, and with the patient 75,000, I would give this patient, I think I personally, off-label, okay, officially 10 BID, but I personally would start with 15 milligram BID, because I always have learned that, the disease burden gets less and the counts very often improve, patients do well. That's why I always prefer ruxolitinib as a first-line treatment, because of the general tolerance of this drug.
I suppose the other thing, just to add to that, is this is the drug where we know there's a survival benefit, right? And we know well how to manage it. We haven't really seen, I'd like to see a bit more data for momelotinib and thrombocytopenic patients, and a bit more maybe for fedratinib. So for myself, I would agree, but it might depend a bit more about the profile of the patient. Are they also anemic? Because anemia often goes with thrombocytopenia, and how well are they likely to tolerate that? So I know you picked grey zone on purpose, because it is a grey zone and it's often a bit tricky, isn't it? And how you manage that. And it's quite pertinent there that the EXPAND study with ruxolitinib and ruxolitinib dosing has just been published, showing that you can effectively dose with ruxolitinib there. But some patients, their platelet count goes up, but other patients, their platelet count is going to plummet. And we don't really know well how to identify that. So that's a challenge.
So maybe, Claire, you hit on something that's important that I'd like to ask Tiziano is A, do you believe that there is a survival advantage to ruxolitinib? And B, do you think that survival advantage would be across all JAK inhibitors, or would likely be preferential to ruxolitinib?
I would see in a patient like this, I will wait. If there is no urgency, I will follow this patient and to see what happens. I'm not terrorized for the number of platelets, 75,000. I would say, let's see what happens in the next 2-3 months. And then I will take my decision. So I need a follow-up before taking the final decision, whether to treat or not to treat this patient. I agree with Claire. You should declare with your patient what is your purpose and whether your aim fits with the aim of your patients as well. So these are borderline situations where the decision should take from you and from the patient as well, I think. So the only way, don't take urgent decision just because you have a low platelet number. Wait at the moment and see what happens. Could be you can wait.
Tiziano, what about the point about survival as a goal? So what if the comment is ruxolitinib is associated with survival?
Yeah. You know, we have some data published recently on survival by ruxolitinib in myelofibrosis. You know, in our registry, we observed in more than 1,000 patients. Those patients on ruxolitinib, as compared to those treated with hydroxyurea, we observed an advantage for ruxolitinib-treated patients. But if this is the story of an observational cohort of patients, but you are talking about a single patient. In the single patient, you cannot promise him to get an improvement of survival. You have to tell the patient what are the data, but in the single patient, so the interest is, of course, is survival. And you know better than me that the only way to have a long-term survival is to offer bone marrow transplantation. There is no point about that.
And Jean-Jacques, do you think that the survival advantage of ruxolitinib is particular to ruxolitinib, or was likely a class effect that could be, as Tiziano was pointing out, in groups of patients, not a single patient perhaps, but in looking at groups of patients?
That's a very important question. I'm not sure I have the right answer there, but clearly there's, well, at the beginning of the use of ruxolitinib, we treated the most advanced patients with very high inflammatory status that were just about to die, and they survived much longer than expected, clearly, with ruxolitinib, probably in part due to its anti-inflammatory effect that reduces all the inflammation and all the symptoms, the constitutional symptoms, where patients gain weight, etc., etc. I'm not sure it's exactly the same for the others, but maybe there are some results that have been shown for momelotinib in patients with anemia, for example, with pacritinib also. So I think it's maybe a benefit from all the classes, from all these class of drugs, although maybe to various degrees. But there's clearly, in my opinion, a survival advantage to receive these drugs compared to all the previously used drugs, such as hydroxyurea, for example, that has no impact on survival, to my knowledge.
Then to keep the discussion moving and time in consideration, if one were to think 5 years in advance, where there may be multiple agents that are under clinical investigation, approved and available, and I open this question to anyone, is do you expect that we will stop using single agent JAK inhibitor therapy when we initiate treatment, and it will be a combination therapy approach? And if so, will there be biomarkers or clinical profiles that will determine which patients should get combinations versus single agent, and how one would even choose if, for example, there was PI3 kinase inhibitor, BCL2 inhibitor, BET inhibitor, maybe a MDM2 inhibitor approved? How will one make a decision in that complex world? It's been easy so far.
Like being in a sweetie shop, all those different options. Well, I think we need a bit more data really to really understand, you know, like maybe MDM2 inhibitors work better in patients with elevated MDM2 levels. And the same maybe for drugs like navitoclax. Maybe they work better with patients who've got overexpression of, or a particular combination of mutations. I think we need a bit more information.
So Claire, that's a great point. So do you think that there will come a time where even in the commercial space, we will run profiles of patients looking either at gene expression or protein expression of these biomarkers that may help guide therapy?
I'd love it. I'm not sure we're ever going to really have the data, because that needs to come, it tends to come a bit more in a kind of after event translational setting. But it would be really nice if we could see that. I mean, I'm thinking about your data with the imetelstat John, showing that, for example, triple negative patients. So that's something that's quite simple. So you could see we'd mostly have that information because we're talking about driver mutation status. So that's possible, isn't it? That you could think about something like that. I was just thinking forward and thinking, when we have all these JAK inhibitors, how are we ever going to decide which one to combine with which combination partner, and how are we going to design those kind of trials? That's going to be a challenge as well.
I agree with Claire that we need more data because there are very promising results, preliminary results, but do this combination really change the evolution of the disease? Can they reverse the fibrosis for some of them or eradicate the malignant clones? There are some promising results, but we need more data to be sure of that, to define the profile of patients, because we also have to take into consideration the will of the patients, because they are often reluctant to take 2 drugs or 3 drugs instead of 1, especially when you have those first-line results with JAK inhibitors in general that are quite spectacular for all of them, and they don't want to be exposed to additional toxicity or more complex treatments. So we will need to have data to justify and explain why we need sometimes combination therapy versus JAK inhibitor alone, at least at first-line therapy. Of course, the situation is different after loss of response.
I agree. But another point that should be considered with these new drugs, I think, you have to establish, and the clinical trials should do that, the risk-benefit profile of each drug. Otherwise, it's difficult for the utilizer of these drugs to make a choice, to talk with your patient. You should be aware that for these diseases, the point of efficacy is, of course, important because you want to solve a problem of your patient. But the same important, or even though more important, is the toxicity due to these drugs. We should be very cautious of that. You cannot be too enthusiastic of the outcome. That could be also a good outcome, but what is the price of this in terms of toxicity? And this should be discussed with the patient. So before asking this, you have to show me what is the efficacy and what is the toxicity of this drug.
In my little experience, we have noticed that some patients with erythromelalgia and other symptoms that are unbearable for them, if you put them on the Ruxo, some of them respond really well, although they are not very severe patients, but it helps them with this kind of symptoms. I don't know if it's more or less anecdotal. It doesn't influence overall survival, but it can help their life.
Inflammatory drug.
Right. Yeah, you say that cortisone would do the same, right? But,
yes.
Okay.
Maybe.
Okay.
Also has side effects, though.
Yeah. Right.
I mean, this is the thing, isn't it? I was talking about this to somebody from a blood cancer charity this week. Like, where would you intervene if I gave you unlimited money? Where would you intervene in MPN? And I think it's got to be trying to treat earlier and really understand our endpoints better.
Yeah.
And then we sometimes have to manage less toxicity. I love your data, Jean-Jacques, about treatment discontinuation potentially as a target. I mean, maybe that's a bit far-fetched for MF, but for the other diseases, it's a good one. But off topic for today.
This is a big problem, sustainability of this drug. And this is the decision of a doctor. A doctor has the evidence from clinical trials, but they have to apply this evidence to the single patient. And the single patient means the public health in that particular country, sustainability, the patient circumstances, and so on. So this is why I liked the proposal done before to talk about the application of clinical guidelines in clinical practice. What is the challenge to apply these guidelines in the single patient in each clinical practice circumstances? This is a very important point. I like this to be discussed by Hub in this setting.